All right, let's talk about a topic that is absolutely high yield for your board exams: rheumatic fever. Whether you're deep in PANCE prep or just want a solid clinical refresher, you've got to know this stuff. So let's jump right in. So think about this for a second. What if a simple sore throat, something pretty much all of us have had, could actually lead to permanent, irreversible heart damage? It sounds almost unbelievable, right? But that is the central, terrifying reality behind rheumatic fever. It takes a routine group A strep infection and turns it into a systemic illness that can scar the heart for life. That's the weight of what we're dealing with here. So how in the world does this even happen? Well, the whole problem boils down to a massive betrayal by our own immune system. This isn't the strep bacteria marching down and attacking the heart directly. No, this is all about our body's own defense system getting completely confused. It's a tragic case of mistaken identity. And the key term you have to know for your exams is molecular mimicry. Here's the best way to think about it. The group A strep bacteria wears a kind of disguise. It's covered in this thing called M protein. The problem is, this disguise looks an awful lot like proteins found in our own heart, our joints, and even our brain. So when our immune system makes antibodies to fight the strep, well, those same antibodies turn around and mistakenly attack our own cells. It's devastating, a true case of friendly fire. Now, you really have to pay attention to the timing here because it's a classic clue on an exam question. This whole thing doesn't happen overnight. First, you get the strep throat. Then there's this quiet period, usually about 2 to 3 weeks long. This is the latent phase, where that confused immune response is just brewing under the surface. It's only after that delay that the signs of acute rheumatic fever actually start showing up. And this isn't just some textbook disease. It has a massive, tragic global impact. Rheumatic heart disease, which is the long-term damage from the fever, is responsible for a shocking 320,000 deaths in young people across the globe every single year. It's a huge problem, especially in developing nations. Okay, so if we're going to prevent those deaths, we need a fast, accurate diagnosis. And for that, we need to crack the code. For the PANCE, that code is, without a doubt, the Jones criteria. You need to know this inside and out, forwards and backwards. So here's the magic formula you have to remember. It's not enough to just have one symptom. You need a very specific combination, either 2 of the major criteria or 1 major plus 2 of the minor criteria. And this is the part people forget. You absolutely must have proof of a recent group A strep infection. That could be a positive rapid test, a culture, or rising antibody levels like an ASO titer. And here they are, the whole menu of options. On the left, you've got the 5 major criteria. These are the heavy hitters. On the right, the minor ones, which are less specific but still really important supporting evidence. A key distinction for your exams: arthritis, actual joint inflammation, is major, but arthralgia, which is just joint pain, that's minor. Don't mix those up. Okay, if you remember one thing from this, let it be this mnemonic. For the major criteria, just think J harness. It's perfect. J is for joints, specifically that migratory polyarthritis that hops from one big joint to another. The heart symbol, of course, is for carditis, which is the most serious part. N is for nodules. E is for erythema marginatum, that weird ring-shaped rash. And S is for sydenham chorea, those jerky, involuntary movements. Just lock J-harness into your brain. Now, while you've got to know all 5, it helps to know which ones you're most likely to actually see in a patient. And by far, carditis and arthritis are the most common. You'll see them in the majority of cases. Chorea is next, but the skin findings and the nodules, they're actually pretty rare. So, if you've got a patient with a fever and a swollen knee a couple weeks after a bad sore throat, rheumatic fever should be screaming at you from your differential. All right, so you've used the Jones criteria, you've made the diagnosis, now the clock is ticking. We need a solid response plan to manage this acute attack and, most importantly, to protect that heart. The strategy here is a logical, 3-pronged attack. First, supportive care. This means strict bed rest, okay? We've got to reduce the workload on a heart that's already inflamed. Second, you have to get rid of the trigger. That means wiping out any leftover group A strep. And third, you have to calm down that out-of-control immune response with anti-inflammatories. So, what's in our toolkit? Well, for the antibiotic, the go-to is a single shot of long-acting benzathine penicillin G. Done. To fight the inflammation, aspirin works wonders for the fever and that awful joint pain. But, and this is a big but, if there's severe carditis, we have to bring out the big guns. We escalate to corticosteroids, like prednisone, to protect the heart muscle itself. So, managing the acute attack is really only half the battle. The true long-term game is all about preventing this from ever happening again. Why? because every single recurrence causes more and more permanent damage to the heart valves. It's so important to get the difference between primary and secondary prevention straight in your head. Primary prevention is what we do for literally anybody with strep throat. We treat it with penicillin to stop rheumatic fever from happening in the first place. Secondary prevention is for patients who have already had it. We give them long-term antibiotics to make sure it never, ever comes back. So how long does this secondary prevention go on for? Well, the answer, which is super high yield, is right here in this table. It all depends on how bad the heart involvement was. If a patient had no carditis, you might stop at age 21. But if they had carditis that left behind actual heart damage, they might be on antibiotics until they're 40, or even for the rest of their life. And this quote right here explains why we're so strict about those guidelines. The risk of another attack is way higher in patients whose hearts were already hit the first time. Each recurrence is like another blow to the heart valves, leading to more scarring, more dysfunction. That's why we have to be so aggressive about preventing them. And to end on a really sobering but critical point, the prognosis is tied directly to the heart. For a child who develops severe carditis with cardiomegaly, that's an enlarged heart, the outlook is grim. A shocking 30% of these kids will die within 10 years. This just hammers home why every single step, from diagnosis to prevention, is so incredibly important. When you think about it, we have the tools, right? We know how to diagnose it with the Jones criteria, we know how to treat it, and we know how to prevent it from coming back. The challenge isn't a lack of knowledge. It's a gap in actually doing it. So with 320,000 young lives lost every year, the real question is, how do we close that gap and make these life-saving strategies a reality for everyone everywhere?